Yeah, good morning everybody. Thank you Neeraj for including us in this instruction course. So I'm going to talk about a few tips and tricks what you do when you are planning for a vitrectomy for endophthalmitis. So these are the headings under which I'm going to talk about, and some indications when do you actually do a vitrectomy in an endophthalmitis patient, what are the tips and tricks, and what complications do you face, and what's the prognosis. Now the indications for vitrectomy is when you suspect a fungal endophthalmitis, when the endophthalmitis is severe. That's according to the EVS study, they said that anything which is hand movements and bursts, that is PL, then you could take it up for a surgery, but in routine practice we really don't follow that. I always feel that a vitrectomy is definitely a good option of treatment because we can debulk good amount of organisms out of it, and we can inject a fairly good amount of antibiotic in that and do a better job. You'll be surprised to know that even patients like simple low-grade endophthalmitis like P. acne endophthalmitis with a plaque also would require a capsulectomy and some amount of vitrectomy. You'll be also surprised when you start following up these cases that even a P. acne endophthalmitis can go into phthisis. It's just that I still remember way back in '98 when me and Neeraj were doing fellowship days with Dr. NSS. We had a VIP, a vice chancellor of a university, who came to us with a simple, at the end of 3 months, with a simple plaque in the posterior capsule, recurrent inflammation, responding to steroids and coming back. I think after that man underwent almost 6 or 7 surgeries. Ultimately, from a 6 seeing eye, it went into a phthical eye. So don't be under the impression that a severe endophthalmitis will always have a bad prognosis and a low-grade endophthalmitis will have a good prognosis. Sometimes even a low-grade endophthalmitis can make a menace when you are trying to treat it. Another very important indication is bleb-related endophthalmitis. It has been shown very clearly that any patient who has got a trabeculectomy done, or any blebs could be either because of trabeculectomy or it could be because of tubes inside the eye. And if these are the endophthalmitis where the doing vitrectomy rather than giving alone intravitreal antibiotic injections alone seems to have a better result. And any intravitreal antibiotic, like now Saurav had given us that you need to give intravitreal antibiotic in a patient when you see when you suspect an endophthalmitis. If it is not responding, you don't have a choice but to do a vitrectomy in these patients. And endophthalmitis associated with RD, which actually Dr. Ajay has already pointed out, any traumatic endophthalmitis with a retained intraocular foreign body, you don't have a choice but to do a vitrectomy in these patients. The biggest challenge when we are operating in an endophthalmitis patient is the clarity of media. If you can see everything, then it's very easy for you to operate. It's very easy for you to operate. Now, the challenges are the corneal clarity, there's some membranes or exudates in the AC, there could be thickened posterior capsule, there could be thickened anterior hyaloid face, then improper pupillary dilatation. And there are some small tips and tricks what you can follow, which we need to remember when you actually treat a patient with endophthalmitis. The corneal epithelial edema could be by just passing a dry cotton swab onto that, or you can scrape the epithelium. I generally don't do the scraping of epithelium. I usually pass a dry cotton bud, then roll over it. Folds on remember that all patients, majority of these patients with endophthalmitis who have got an intense anterior chamber reaction do have some form of endothelitis, and that tends to produce a little bit of descemet folds. Injecting visco onto the endothelium definitely helps a view a little better. Now, removing of the pupillary membrane is a very important thing. That's something, and we all think that by removing the pupillary membrane, after removing the pupillary membrane, the pupil doesn't remain dilated. But you'll be quite surprised. You'll be quite surprised that actually, when you remove the pupillary membrane and sometimes even the retropupillary membrane, you will actually see that the pupils do remain dilated. Some people try to use adrenaline on the table, but I generally try to watch. Say, no, you see such a bad membrane which is there in the anterior chamber. The trick here is to identify the edge of the membrane. That is the most important. See, now we have identified the edge of the membrane, then you can use all the trips on your sleeve, whether you can use a dialer to pull it out, or you can use an end dripping forceps, or you can even use your Macpherson, whatever you want. You have to pull this exudate out from the AC. Now you can see that. You will be quite surprised with such a large exudate, this pupil also tends to remain reasonably well dilated inside, and you will be able to perform your vitrectomy. And you see at the end of it, once we did a good AC wash in this particular patient, you can see that you are able to go ahead and do the surgery in these patients. So it does not always mean that with a membrane in the pupillary area does not always mean that the pupil will not dilate. The pupil would also be dilated, and mid-dilated are sufficient enough for us to do our surgery. Another important thing is you should learn that there are a lot of exudates which tend to go and get themselves locked in the bag. So it's always wise to wash the bag, and sometimes there are exudates behind the IOL which needs to be removed. A thickened posterior capsule or a thickened anterior hyaloid phase is better handled by the pars plana route. And in case of fungal endophthalmitis, remove that. It's not only removing of the IOL. At times I see people only removing the IOL. You need to remove the IOL along with the back. That's a very important thing. Few small things which we routinely follow, all of us. I'm sure everybody is well versed with it. But just to remind them is a longer infusion cannula would be of a benefit. A undiluted sample tends to give a better yield when you're doing a culture sensitivity or thing. A good core vitrectomy. I do not aggressively advise to induce a PVD. If PVD already exists in this particular patient, then you can just go ahead and do your good amount of vitrectomy. If PVD is not there, do not aggressively induce a PVD. It is really not necessary to induce a PVD. Avoid going very close to the retina because there are two important things which can happen to the retina. The retina tends to be edematous. The second thing is the retina is ischemic, especially if there is some amount of vasculitis component which is seen in these patients with endophthalmitis. So an ischemic and an edematous retina is a very dangerous combination because any slight pull and push can cause a break or a heme in that particular area. Another problem which you can actually face when you actually trying to do a vitrectomy is the dense inferior skirt. And sometimes we get so, you still see the skirt, you want to keep cutting the cut, you want to keep cutting the skirt, and sometimes you land up in problem. And a gentle depression inferiorly can also help you out in clearing majority of the vitreous skirt. Pre-retinal exudates, majority of the times if they are free and if they are easy to pull out, I tend to use a passive section, that is a flute needle, to pull it out. But if it is stuck very badly, I think you can just leave it alone, you don't have to really worry about. Now these are some videos which I'd just like to show you. Obviously the view is not going to be great, but you need to understand that when you're doing a vitrectomy in such a patient, what I was talking about is the PVD. Here, So here you can actually see that when the PVD is quite loose and you can actually eat away that excess amount of vitreous which is there in the inferior part. And now you can see that the loose area there, that loose area, the dense exudate there can be easily removed because the PVD already exists in this particular patient. And the moment you clear that off, you can see the view of the retina has become, and that's where you should learn when to stop. And that's extremely important. That's extremely important for us. And this is another video which is just showing you that by just injecting a visco into the anterior chamber, because visco also helps you to maintain a little bit of pupillary dilation. So that's one more trick which you can use. See, by the time you inject visco and you can wash, you can see when you peel off that particular membrane, you can see this much amount of dilatation is sufficient for us to do your vitrectomy process. And there are at times when you finish your vitrectomy, you tend to see those whitish things, pre-retinal exudates which are stuck onto the surface. You can see a whitish one onto the surface of the, really very close to the fovea here, in the center area. And that whitish one, if you are able to aspirate it out, well and good, otherwise you can always leave it. I think Dr. Saro has already mentioned when you are injecting an antibiotic injection, you should always have a bevel faced up. Do not direct towards the macula. Always have a gentle injection. I have seen my fellows actually having a very rough injections and landing up in problems on the table. And avoid an elevated IOP. The two ways which we can do it is, in a patient who is undergoing a vitrectomy is, at the end of the surgery, you can close one port, you can switch off the infusion, create a bit of hypotony, then inject your injections, then close it up. Only thing is you need to place a suture in advance so that it can be easy. Other thing, the biggest advantage is in this particular technique is you can actually titrate the pressure at the end of the surgery. You will not create a hypotony. The second one is at finish of your, close your conjunctiva, then inject your antibiotics with separate needles. That's your choice, but I prefer the first one. It's very easy and it's quite simple. Now you can create any complication with the endophthalmitis patient, right from damage to the cornea, to the iris, to dropping an IOL, to producing a break or a retinal detachment or a choroidal detachment. But the two most important complications, to me, the most important complications which actually bugs, especially in a low-grade endophthalmitis or in a patient with a fungal endophthalmitis, is hypotony. Hypotony is something which is very, 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 very difficult to control in this. And another most important thing what people do is, in the name of core vitrectomy, they actually do not debulk the vitreous. It's actually as good as doing a tap and giving an injection. It's actually doing a tap and injection, which is, I call it as incomplete surgery. Another important complication is you should learn when to stop doing the surgery. The moment you have seen the retina, you should not be overzealous to go and do a base excision, do remove the entire skirt, which is not possible. You will not have a view in majority of these endophthalmitis patients. Very important thing is post-operative treatment is important. Antibiotic needs to be continued for a certain period of time, oral antibiotics or systematic antibiotics. Antifungals, there are instances where we have to give antifungals for as long as 3 to 6 months. The most important thing, after vitrectomy, the treatment doesn't end there. If after 48 to 72 hours, if you still feel that there is no improvement or there is a worsening of the case, that's the time when you need to repeat your intravitreal antibiotic, or you need to do a vit lavage depending on that particular case. So that's one of the very important. It doesn't stop at vitrectomy. That's very, very important. So these are the prognostic factors in vitrectomy. If good visual acuity prior to the surgery, a better prognosis. The greater the virulence of organism, the lesser the prognosis. Culture negative endophthalmitis tend to do a little better. Delay in treatment obviously has a poor result, and the presence of a retinal detachment of choroidal detachment is a poor prognostic factor. So the take-home message is, know your indications when you do your vitrectomy. Clarity of media is extremely important when you operate, and I've told you a couple of tricks how to improve the clarity of the media. Debulk as much as vitreous as possible. Do not induce a PVD or force a PVD if it already exists, well and good. Beware of the skirt of vitreous, especially the inferior skirt. Be careful when you are injecting an intravascular antibiotic inside the eye, even in a vitrectomized eye. You can cause a damage to the eye. Avoid incomplete surgery. Learn when to stop, and remember that post-operatively, after 2-3 days, if the eye is not responding, you need to repeat a treatment in that particular patient. Thank you for your patient hearing.